Thank you very much for joining us for PMOPA's first webinar of 2024. I'm Mike Nichols, PMOPA's CEO, and it's my pleasure to moderate this program today. Many of us have set New Year's resolutions to eat better, exercise more, and take better care of ourselves. So it seemed appropriate to start off our 2024 webinar series with a topic that's near and dear to all pilots, our FAA medical. I'm pleased to introduce you to Dr. Keith Roxo, who is the Operations Director for Wingman Med, which was founded to help pilots maintain or regain their FAA medical certificates. Keith is a former military pilot with over 2,000 hours in high-performance aircraft, including the FA-18, F-16, and F-5. He holds multiple military flight instructor qualifications. He's an airline transport pilot certificate holder and a CFII. He also owns a Bonanza. Maybe we can get him to upgrade to a PA-46 soon. And he is also an aerospace medicine physician and board certified in aerospace and occupational medicine, and is an FAA senior, HIMSS AME. We'll have a Q&A portal open throughout the duration of Keith's presentation, and it's available to you to type in your questions. Following Dr. Roxo's presentation, we'll answer as many questions as we can, so don't be shy. But questions specific to your particular medical situation may not be possible to answer without additional information, so please understand if he needs to defer. Keith, thank you very much for joining us this evening. Let me turn it over to you for your presentation.
No problem, and thanks for having me. So what we're going to talk about today is how to get through the FAA medical certification process as quickly as possible. When you go in for your FAA medical, there are three potential outcomes. You can be issued your medical certificate, you can be denied your medical certificate, which is very rare, or your exam can be deferred to the FAA for further review. The FAA is processing about 450,000 exams this past year, 2023. So that's a lot of exams that they go through. Approximately 5 to 8 exams per year are deferred. So that's about 20 to 35,000 exams per year end up in this deferred process. And when an exam is deferred, it typically is going to take anywhere from 6 to 9 months or more, depending on the situation. And that's not really a time that you want to be without the use of your aircraft. About 1% of exams are denied every year. Now, the exams that are denied, it's most commonly due to paperwork errors, and it's not typically because the person is actually not medically qualified. Now, that does sometimes happen, but in general, it's due to poor communication between the pilot and their physician team and the FAA. And we'll go into why that happens. So yes, that is me. I am Keith Roxo. I am a Top Gun trained adversary pilot, and I flew the F-18, the F-16, and the F-5. And then I went to medical school. I thought, why not? So I went to the military medical school, and I stayed in the military as a flight surgeon, became board certified in aerospace medicine and also occupational medicine. And then my business partner and I, Dan Monlux, who did all the flight training with me, and actually the guy I stole the idea of medical school from, we both decided to start this business together as we, became senior flight surgeons in the military, and friends of our friends who were airline pilots needed help. And then it just kind of grew from there. So today we're going to talk about the FAA medical certification. Yes, I do have a Bonanza. I understand you guys may want me to upgrade, but I am an ABS Life member. So maybe one day you guys can have a Bonanza and join the American Bonanza Society as well. So here's our outline. We're going to talk about the approach to the exam, filling out MedXPress, the FAA AMCD, so that's the Aerospace Medical Certification Division, what proper medical documentation looks like, getting that note from your doctor. We're going to touch on some mental health issues, and we're going to touch on BasicMed a little bit as well. The exam. So the purpose of the exam is to certify you as safe for flight. A common misconception when I talk to pilots is they think that this is just another routine checkup with the doctor, and it's not. It is the DPE. So if you remember back when you were doing your check rides, the designated pilot examiner was the guy signing you off to get your certificate. He was not the guy giving you instruction. And that's the difference between your treating physician and the AME and the FAA at large. They are certifying you safe for flight. They are not there to provide the treatment. And so they look at things in a different way. The purpose of the exam is to establish that suitability for a very specific period of time. Your pilot certificates do not have an expiration, but that medical does. So because of that, they need to have the most current information in order to make a disposition based on the next specific set of time. Now, federal law does require you to disclose the information, and a lot of people ask about HIPAA. HIPAA does not apply for a couple of reasons. One reason is that you are legally obligated to disclose the information for a voluntary activity. It is not a requirement to fly. And the FAA sets the medical certification requirement. So it's kind of like not only is it their ball, but it's also their field. And so if you remember playing as a kid, the one who didn't want to play would take his ball and go home. Well, they have the ball and they own the home or the street or the park or however you want to describe it. Also, HIPAA does not apply to the federal government in this situation. It only applies to what are called covered entities, and the federal government at large is not a covered entity, and the FAA medical certification folks in particular are not a covered entity. And lastly, HIPAA does not apply to you disclosing your medical information at will, which is effectively what this is because the FAA requires it. So as we go through, we're going to talk about a few different parts of the exam. Specifically on MedXpress, this is how people need to communicate to the FAA. Specifically, when you have a new medical issue that is of concern to the FAA, and we'll cover that in a second, but the best way to communicate to the FAA is via a new exam, starting with MedXpress. Now, if you're sick for a few days because you got the flu, do you need to tell the FAA about that? Not necessarily. Do you need to do a new exam? Absolutely not. You need to self-ground until you're better, and then you'll be able to fly again. But if you have a significant issue, you have a major abdominal surgery, or you have a traumatic car accident with significant injuries, or you're diagnosed with a new concerning medical condition like diabetes, well, then the date on your paper copy of your medical certificate is not really valid any longer. It expired the date of that major medical issue. So each part of MedXpress is there for a specific purpose, and we're going to go through this, but some of the older pilots may remember the actual paper form, this 8500-8, and now we use the digital MedXpress format. And so there's several sections, and each section has a purpose. And they could simply say, tell me about your medical history. That would kind of be the easy way to ask. But invariably, people are going to forget things. And it's not that people are forgetting things on purpose. I know when I see a patient in the clinic, sometimes we'll start off with a history of, okay, tell me about your past medical conditions. And they'll say, oh, I don't have any. And then I say, well, tell me about your medications. And they tell me they're on high blood pressure medicine. Well, they're not lying to me about not having high blood pressure. They just didn't think of it because they've either had it for so long, or they take a medication for it and they think the medication corrects the high blood pressure, which it does, but it doesn't mean the disease does not still exist. So what they do is they ask a bunch of different questions as memory triggering devices to get a complete history of your medical situation. And one of the goals is we want to tell a consistent story. So medications is pretty straightforward. If you're taking something, you need to list it. If some people try and game it. Well, I didn't take that medication today, so I'm not going to put it down. If it's a medication that you take on a regular basis, even if you don't necessarily take it every day, you should be listing it on there. You may feel that sometimes you're fine on all of these medications. We actually have an article that's going to be coming out in the ABS magazine and will be later published on our website that talks about the varying effects of sedating medications and how the impact can last much longer than you think. So that is why the FAA wants to know about medications. You may feel fine on it at 1G and 0 knots, but when you're up at altitude and you lose pressurization in your aircraft and all of a sudden the oxygen drops down and your autopilot breaks, that's not the time that you want to know that or figure out that a medication is causing you problems. And per the NTSB, at the end of the 5-year study in 2017, 28% of pilots in fatal accidents had a medication in their system that was most likely causing some problem with them in flight. Now, they're not attributing those accidents to the medication use, but it was clear that people were not doing their due diligence. After medications, it talks about very specific conditions. And there's a statement in there that says, have you ever in your life? So while the medications are, what are you taking now? The medical conditions are, have you ever had in your life? Now, for some of us, that can be a long time and it can be a little bit difficult to remember. That's why one of the techniques we recommend is as you close out your MedXpress towards the end, you'll have the option to save it as a PDF document. And ideally on your computer, you'll have a folder. And in that folder is where you save all of these 8500-8 documents. That way you can just look at the last one that you did and you can just copy and paste the answers and add anything that's new. Sometimes we'll hear the pilot say something like, well, they didn't ask me about my sleep apnea. But if you look at item X on that picture in there, it says other illness, disability, or surgery. And that's kind of the FAA's catch-all. If we didn't ask specifically about the condition, but you have a major condition, that's where it would go. That's where your knee surgery would go, or your shoulder surgery, or your sleep apnea, or anything else that's not specifically listed. Taken together, you can kind of look at this as the FAA is basically saying, have you ever in your life had any illness, disability, or surgery? There's a few more memory jogging questions about disability status, and that's most typically going to be Social Security or Veteran Affairs disability. There's going to be questions about military medical separation or disqualification. Again, these are all just ways to try and trigger the memory. So when you're filling this out, you want to tell a consistent story. You don't want to get to the AME and have that AME asking you a whole bunch of questions. He has to take what you have provided and submit that to the FAA. He's going to add some updates as appropriate, but the easier you make it for the AME, the easier your exam is going to go. One of the things that the FAA has put out recently is that the use of previously reported no change is no longer allowed to be submitted. We put that out on our social media just a few weeks ago, and there was a lot of angst from pilots about that. And some of them were very quick to point out that the MedXpress instructions say that you can use previously reported no change. And while that is technically true for you as the pilot, the AME is being told by the FAA they cannot submit it as that. And if you think about it, not everybody uses the same AME exam after exam after exam. Even if you do, and you're operating on a third-class medical and you're under the age of 40, that's every 5 years. Even over 40, it's only every 2 years. So that doctor, that AME may not remember everything that you discussed 2 years prior. So what the FAA wants is for the AME to actually investigate each and every issue. If they don't know what the story is for that item that says previously reported no change, then they're not going to accept it from the AME. To the FAA, that AME has no knowledge of what it is. So what we recommend is to be pretty detailed in that answer. For example, left knee surgery, August 2020, reported on my December 2020 exam, no change. You're saying the same thing, previously reported, no change, but you're providing enough detail for that AME to be able to work through that situation. Once you have submitted all of your stuff through MedXpress, that's it. You can't edit it. But if you realize you made a small error, that's okay. The AME is working from the same answers you submitted, and he can edit those answers if you do have some updates or you forgot one or two little things. If you really don't like how that turned out, if you made some pretty significant errors, you can wait 60 days and it will auto delete. And then you can start a new one fresh. That is a good bit of time, so I recommend you not do that if you want to get through quickly. But by ensuring that you tell a clear and consistent picture to your AME, or story, I should say, to your AME, it makes things a lot easier. So a couple of examples. I take no medications, I have no medical conditions, but I've been to a cardiologist 6 times in the last 4 months. That is not something that really adds up. The AME is going to want to know, why have you gone to the cardiologist 6 times in the last 4 months, but you say you have no medical concerns? Sometimes people will argue, well, I don't have a diagnosis yet. Okay, well, the FAA still wants to know about your non-official diagnosis heart problem, because that is going to be concerning. And this kind of leads to another idea of, don't go in for your exam if you're not ready for the exam. It is a check ride every bit as much as the private or instrument or commercial check ride. So you need to make sure that you're ready to pass, or as close to being ready to pass as possible. So having a diagnosis still in workup and development is not a good time to go in for your FAA exam. So some notes that we have here: list a medical condition for every medication or disability. If you're taking a medication, you should be taking it for some particular reason. If something doesn't fit, that's when it goes under that other illness, disability, or surgery. Provide that brief statement about each medical condition. If you need more than one sentence, it's a good idea to bring a note from your doctor. If you can't summarize it kind of in that example sentence I gave, you probably need a full note from your doctor that does a good job explaining it. List a reason for all healthcare appointments. We'll get a little bit more into healthcare appointments later on. And the AMEs can't see your previous exams, like I mentioned before, and then retaining those copies, like I talked about. Now we're going to talk about the FAA Aviation or Aerospace Medical Certification Division. So these guys are not all doctors, in that they have some clerical employees and they have some folks who do the initial paperwork review. But essentially, what you need to understand is it is run by physicians. The final reviewers of all the cases are physicians. Many of them are primary care. Some of them are specialists, such as ENT, cardiology, ophthalmology, things that are very pertinent to aviation medicine. But like any bureaucratic part of the government, they have very little control over their own working environment. They do not control many of the rules in which they operate. A lot of those are written by Congress. They do not control their own budget. They do not control the computer systems. We get questions a lot, like, why can't AME see the past exams? That's a great question. The answer is money and system limitations. And the Aerospace Medicine Certification Division does not have the money or the control over the computers and the MedXPress system to make it that way. That is on their goal and their goals. I believe that's part of their 3-year timeline that they're looking to do. But they have to lobby Congress for the money to make these kind of changes. And that is something that is difficult for them. But the important thing to know is that they are physicians, but they are not your treating physician. So they understand the medical information that is sent to them, but they're looking at it in a different way. Your paperwork is all that goes to the FAA. And you'd be amazed at some of the things that we've seen be sent into the FAA. Recently, we were working up a case with a client who he's been battling the FAA for quite some time. And I'm not surprised. Nothing that he sent to the FAA is in any way, shape, or form relevant to the medical conditions that he has in the form that the FAA wants them. They want very specific information, and his team of physicians they were just not giving him what the FAA needed. What is needed for treatment and what is needed for aeromedical risk analysis is not the same. And the other thing that goes along with that is when you see a doctor, typically that doctor is, one, focused on your treatment, but number two, he also wants to get paid. And number three, he doesn't want to get sued. So for payment and suing, that's what drives his documentation. He needs to document enough to not be sued and also enough to get paid. Those things do not necessarily equal the detailed level of notes that the FAA wants. Now, part of that is just a regular system of medicine, in that if you see me every 3 months for an ongoing condition that we're trying to get you better from, I'm not going to write a complete medical school style note every single time you're in my office. I'm going to write what's called an update note. It's going to update the previous information. Well, for the FAA, they want one complete note from the start to the end. They don't want all these past notes. They don't want all this extraneous information. If you go into your My Chart or whatever for the hospital system or a physician's practice that you use, there's all kinds of ancillary pages and pages of information. They don't want to see any of that. It's just fluff and filler, and it drowns them in paperwork. And yes, they have to look at it all. And yes, they will find things that are not necessarily pertinent, but may cause problems. And it also leads to some of the delays that we have. The FAA is currently only manned at about 75% physicians. And when people send in 500 pages of documents when 10 or 15 pages would do, it slows things down. And what they're primarily looking for is that risk to incapacitation. So when we look at that, there's a couple things that come up. Your doctor should be very concerned about your blood pressure being about 145/90. But the FAA is not terribly concerned about that. And that's because high blood pressure is a long-term risk. It is not a next day or next month risk. So your doctor is probably very concerned about that and wants to get you started on medication. If you go to the AME, you're going to pass based on that blood pressure. And the AME may say something like, you should go to your doctor and get this checked out, but it's not going to inhibit your ability to get your medical that day. You have to be over 155/95, which is pretty high in order to not get your medical that day, because now you're starting to run into the realm of this could be a big deal in the next few months. Meanwhile, your doctor has no problem putting you on gabapentin for an adjunct pain medication for some minor issue that you have going on. But the FAA absolutely will not let you fly on gabapentin. And the reason is, going back to that scenario, for guys in bonanzas like myself, if I'm at 12,499 feet because I'm too cheap to buy an oxygen system, but I also want to stay further away from the Rocky Mountains, and I'm in bad weather at night and my autopilot broke and the FAA gives me a new full route clearance, that's not the time to be on gabapentin, because gabapentin is an anti-seizure medicine. And the way anti-seizure medicine works is it slows down signal processing in the brain. Anything that slows down signal processing in the brain is not something the FAA wants you on, because in that scenario at night in the goo with a broken autopilot, again, that's not the time you want to find out that your brain's not 100%. So that's why something seemingly innocuous to your doctor is going to be a big deal for the FAA, because they're looking at it from that incapacitation perspective. When it comes to documentation, one of the big things is this current detailed clinical progress note. And again, like I said before, the level of errors that we see in documentation is pretty staggering. So what is a detailed clinical progress note? One of the big things is timing. So going back to that, they're certifying you for a period of time based on your current situation. Well, what that means is they don't want to see something that's 5 years old. They want to see something that's right now. If you're getting an update on your sleep apnea, they want to know how you're doing with your treatment now, not how you were doing with your treatment 6 months ago or 8 months ago or 2 years ago. So anything that you bring in support of your medical application needs to be no older than 90 days. One of the things that we like to do is we like to prepare people in advance of that exam so you can coordinate everything in the 90 days leading up to the desired date of the AME exam. Or you can just look at when's the best time to schedule everything. And then once you get everything done, make sure your AME exam is within 90 days of the first item that was done. For other documentation, details matter. So this kind of gets into that. So we did current, now we're in the detailed part. So both of these parts of the slides effectively say the same thing, but you can imagine which one the FAA would prefer to see. When it comes to documentation, these are the elements of a current detailed clinical progress note. All of these items need to be in there. And this is where we see many of the errors. It's not a complete history. The medications may be listed, but it won't specifically say that there's no side effects. If you do not say that there are no side effects, the FAA is just going to come back and say, are they having any side effects? And that's a very time-consuming way to deal with the FAA, because anytime they have a question, you're looking at a 3 to 4 month turnaround, because they read the information and they send it to you in the mail asking a question. You may ask, why do they send stuff only in the mail? And why do we not get this information via MedXPress or our accounts in MedXPress? And sadly, the reason is a 1952 law. I was part of a web group with the federal air surgeon, the deputy federal air surgeon was, hosting a little seminar to talk about the state of medical certification. And that is one of the questions they get all the time. Why will you only send information via the mail? Well, it is a 1952 law that requires them to communicate dispositions and directions to pilots via the U.S. Postal Service. There's nothing they can do about it. They would love Congress to change it. They try and slip it into the FAA appropriation bill whenever that comes through. Somebody always pulls it out. It's used as a negotiation tool. So they're kind of stuck with the systems that they have. Physical exam findings, these must be complete and pertinent to the exam. If it's a neurological problem, it has to have a complete neurological exam. If it doesn't, it's going to get kicked back. Results of any testing, diagnoses. This is where things can get a little crazy because people, in order to boost their billing with insurance, they will add extra diagnoses. Every diagnosis has to be explained. Extra diagnoses that are just kind of carryovers and not explained cause problems. And then a plan. So this is effectively all of the stuff that needs to be contained within that note. Now, a lot of doctors will say, well, I don't have time for this, or everything's in there. Well, it's probably not in there from my experience. And when somebody asks or says, well, this is all that's in there, one way to remind them is to say, hey, this is more like a medical school style note level of detail, not a, practice level of detail. So what happens when you can't get the note? Sometimes this happens with doctors who just, they just don't want to do it. We actually see this a lot with cardiologists, and I'm not exactly sure why. Part of it is that they are very busy professionals, but part of it is they seem to be a little bit more arrogant of a group of physicians out there. No offense if there's any cardiologists in the crowd. But that's just what we've noticed. And with that, one thing to keep in mind is going back to who pays that doctor. Insurance pays that doctor and they don't want to be sued. So now you're going back to them and you're asking them to rewrite documentation they've already written. But if you're not offering to pay them for their time, you are now asking a very busy professional to do more work for no more money, which most people are not interested in doing more work for no more money. And again, it's their job to treat you. It's not necessarily their job to give you what you need for the FAA. So the way you go about asking these questions and the relationships that you develop with your doctors are going to go a long way to getting these things. If you have a specialist like this, and no matter what, they're just not interested in helping you out, your next best option is to go to an independent medical examiner. And that independent medical examiner is a professional in the specialty who you are going to pay. These are typically used in insurance cases or workers' comp cases, things like that, where they will do a detailed review of the records, they will conduct their own physical exam, and then they will write a professional note that will meet the requirements. That can be expensive, but it can also be expensive paying you for your airplane that you're not getting to use. And then the other thing is what's called a direct primary care physician. So these are typically family medicine or internal medicine doctors who no longer take insurance. They usually work on a subscription model where you're paying them anywhere from $75 to $150 a month. They have same day or next day access. They do telehealth visits. Largely when we tell a pilot, hey, the faster you get through this, or the faster you get your documentation, the faster you're going to get your medical. And when they've tried their normal doctors and they're not getting good help, we tell them to find a direct primary care. And so far, every single one of them has had what they've needed within a week. And it's been fantastic. And a lot of these people, they've seen the light. They're like, wow, that's what I'm going to do. For the cost of my cable bill or my cell phone bill, I have this doctor on call pretty much all the time. Now, they are primary care, so anything that does need a specialist, like a cardiologist, they're not going to be able to do that kind of stuff. So what other options do you have? Those are kind of the big other options. But what we've seen is that people who commit to the process are the ones who actually do the best. You're dealing with the federal government and the bureaucracy, and trying to fight that bureaucracy usually doesn't go well. We'll have people call us frequently and say, hey, I've been denied my medical and I want you to help me appeal. We don't do appeals. And the reason for that is when you ask the FAA to appeal a decision, what you're asking is the Federal Air Surgeon Office in DC to overrule the decision by the Oklahoma City office. Now, what I can tell you from experience is that if the Oklahoma City office has made an error, you don't need to appeal it. You just need to point it out to them. And when we point out to the FAA, hey, I think there was an incorrect decision based on this information that we have read, They all the time, they don't make mistakes often, but all the time when we've pointed it out, they say, oh my gosh, you're right. Let's get that fixed. So there's no need for an appeal if there was an error made. If there was no error made, you're asking one group of doctors to overrule another group of doctors based on the same information. And if no error was made, that's unlikely to come out in your favor. So that's why we don't help with appeals. If we can't get it fixed because something was done incorrectly by the FAA, then our goal is just to prepare for a new exam, because that means that paperwork was not good the first time. And being denied does not mean you're denied forever. It means you were denied that application. You can immediately do a new application as long as there's no stipulation. Sometimes people are denied because, well, you have a 2-year minimum wait because you had a specific type of head injury. Well, it doesn't do any good to apply before that 2-year wait period. For mental health, let's talk about a couple things. So the analogy I like to use here is if you're riding your bicycle on the street and you see a rock in the road, if you stare at that rock and say to yourself over and over, do not hit the rock, do not hit the rock, do not hit the rock, but you keep staring at it, you're going to hit the rock. So you need to look away from the rock and you will go where your eyes are looking. Mental health is frequently that way for people who very much want to avoid a mental health diagnosis. They stare at that mental health diagnosis in the distance and they say, do not get a depression diagnosis, do not get a depression diagnosis, do not get a depression diagnosis. But what are they actually doing to prevent the diagnosis of depression? Many times, a mental health issue starts off very small. It's not always a major catastrophic event. Now, I'm not trying to slight things that occur in people's life. The death of a loved one is a big deal. A normal reaction is to be sad for a while. That is not a mental health disorder. That is a normal reaction. If 4 or 5 days after the death of a spouse, you run to a psychiatrist who is paid by the insurance company and he wants to bill the insurance company, he's going to diagnose you with something. And he's probably not going to diagnose you with normal bereavement because he's not going to get paid for that, because that's not a clinical diagnosis of concern, or he's not going to get paid much for that. So all of a sudden, you are having normal bereavement. You went to talk to somebody for some professional help, and you've come out with a major diagnosis of concern for the FAA. This is not to say not to get help. You just have to get help in the right way. If you do not need a full-blown psychiatrist or psychologist for help, then do not go to one. There are plenty of people out there that are not even reportable to the FAA. Members of the clergy, not reportable to the FAA. Family counselors, not reportable to the FAA. Family therapists, not reportable to the FAA. It's only when you see somebody at the medical level, psychiatrists, psychologists, licensed clinical social workers, nurse practitioners, those are ones that are reportable to the FAA. There's one more. There are counselors who work in dedicated substance abuse programs or work-related substance abuse programs, even though they are not medical counselors, because it's related to substance abuse, that does have to get reported to the FAA. But that has to get reported anyway because it's substance abuse related, not so much because it was a counselor. So one of the things we like to say is to get help early. If you had a major life event, it doesn't mean it's a major diagnosis immediately. So seek help early from one of these non-reportable professionals or a reportable professional, but you pay them out of your pocket. You don't let them bill insurance, and you talk to them and say, hey, I'm not necessarily here for a diagnosis. I'm here for figuring out coping skills and learning how to deal with this. And, I'm not really interested in getting a diagnosis in one appointment. When you see true psychologists and psychiatrists really work through cases, they spend many sessions really trying to rule out what the potential issues are before they come to this is my definitive diagnosis. But unfortunately, the way reimbursement works, most of the time, they're just going to jump to a diagnosis on day one. So seek help early and seek it from a lower level person that doesn't necessarily have to be reported to the FAA. If those people, after a few sessions, think that you are actually getting worse, okay, well, then it is time to see a medical professional and possibly need medication. And that is also okay. And yes, that may disrupt your FAA medical for a period of time, but that's also okay. There are ways to come back from that. It's better to get treatment and get better and return to flying than to not get treatment, continue to get worse, and still try and fly. So we'll start kind of closing down by talking about basic med. Now, for some of you guys, basic med is a player, but for some of you, it's not. One of the major things is the size of the aircraft. So a maximum takeoff weight of 6,000 pounds is one of the basic, limitations, and then 6 seats. So I'm not as familiar with your guys' airplane as you are, but I think 6 seats is pretty workable. But it's that 6,000 pounds that may or may not get you through. The other issue is 250 knots. Now, I'm not really sure how fast you guys are down low, but that's probably not a huge issue. But the flight levels things, so especially for everybody who has the pressurization models, flight levels are going to be a big deal. But you can't go into the flight levels with basic med. So there are some pretty significant limitations for your type of aircraft under basic med. And then lastly, no compensation. You cannot be paid to fly under basic med. There are also some times when you might need to go back to the FAA. So you can operate on basic med as long as you've had at least one valid medical after, I believe it's July 2006. And you can't have been denied or anything like that. But then there are also times where, despite being on basic med, the FAA wants to give a little bit more review of something. And that's primarily going to be mental health, neurological, or cardiac related stuff. So a significant mental health disorder or condition that you recover from, you're going to have to go back through the FAA process on that. For neurological stuff, so basically any unexplained neurological stuff has to go back through the FAA. Now, with that, I'll tell you right now, if you have an unexplained neurological thing, you're probably not making it through the FAA anyway. For minor unexplained neurological problems, there's a minimum 2-year wait. For major unexplained neurological problems, there's kind of an indefinite wait. Particularly if it keeps happening. And then cardiac stuff, which makes sense. Nobody wants to, see the kind of the old joke about the pilot, passenger looks down the aisle and the pilot clutches his heart and falls over and then the other pilot jumps up and they all start laughing. Nobody wants to see that. Everybody's scared to death of that. So anything real heart related, so any major cardiac conditions, heart valve replacements, heart replacement, heart disease that needs to be treated, heart attack, those technically are going to need a one-time special issuance from the FAA. Once you get that, you can then go back to basic med afterwards, assuming that it works for your aircraft. All right. So now how do we do questions? Do I need to stop sharing my screen?
If you could do that. We don't have any open questions in the queue right away, but
Okay.
I have one that somebody asked me earlier that I thought I'd pass along to you and see what your thought is. So
Okay.
it's gone to basic med, and then they realized that they actually want to go back to having an FAA first, second, or third class medical. Is that
Sure.
possible? Can you go back and forth between being in the system or being on basic med?
Yeah, there's no limitation to going back. If you don't renew your medical because you went basic med and you don't renew your FAA medical, there's no FAA medical police coming hunting you down to find out if you're flying or if you have basic med or anything like that. If you want to go back to the FAA medical, you just have to do a MedXPress. Now, one thing to consider, if you were previously on a special issuance medical and you went basic med because you didn't want to deal with some of the bureaucratic requirements of the special issuance, you will have to meet those requirements when you go back to the FAA medical. And they may want multiple years worth of stuff if it's been a while. So that is, it's not a barrier, but it is a hurdle to get over.
Yeah, thank you. Just a reminder for folks, the Q&A portal is open. If you can type your questions in, we'll be able to answer those questions. Another one that came in offline, Keith, is sometimes folks are hesitant to go to the doctor and address medical issues because of concerns of the FAA backlog and challenges dealing with the FAA. What are your thoughts with respect to that and best practices with regard to taking care of health and balancing that with FAA medicals?
So as a professional pilot, I also feared going to the doctor for, 14 years. I was a pilot in the Navy before I went to medical school, and I didn't want to tell the doctor anything. And then I went to medical school and became a flight surgeon and then an aerospace medicine doctor. And I realized how dumb that was. I realized that what you need to do is prepare like that check ride. Now, there are ways to prepare, and that is the thing that's hard. Your CFI knows how to prepare you for that check ride. There's all kinds of test preps. There's Gleim and King schools and all the programs out there for the question banks to help you get through the tests. But there isn't really many people that can help you prepare for a check ride or for the medical check ride. Now, a lot of folks will say make a consultation appointment with an AME. And that only works if you know what the issue is. If you're not going to your doctor to get treated for something, then you're not going to be able to even ask an AME about it because you don't know what the issue is. So one thing that I will say is it's better to go ahead and start getting treated and then figure out how you're going to get through the FAA medical process. Now, there's effectively three types of AMEs out there. So you have the what I call like the mom and pop AME, right? So it is a primary care doctor, maybe in a city, maybe in a rural area. They don't do AME exams as their primary business model. They sprinkle a few in here and there. They do 5 to 10 exams per year, and they go to their training class once every 3 years, which is the minimum requirement. They're probably a very good doctor. They are probably not up to speed on the latest FAA guidelines. They probably have not seen all the different types of cases that can come through and how the FAA wants those cases dispositioned. That person is going to have a hard time helping you because they're just not as knowledgeable about it. One thing to look at, or one way to look at this is every pilot an amazing pilot? No, they're not. And that's the same with doctors, with lawyers, with police officers, with business owners. Not every AME is a great AME. On the other end of the spectrum is you have what I call the paper mill AME. And by that, they're just churning out certificates. So you're maybe in there for 5 or 10 minutes, boom, you get your certificate, you're on your way. That all sounds well and good until you have a problem, because that guy doesn't have any time in his day to deal with your issues. He's trying to knock out 40 to 45 exams in a day. If you stop him and say, hey, I have this paperwork for my doctor, he's going to be like, all right, I'm just kicking you to the FAA. You can send it to them. Well, that paperwork may have gotten you your medical issued at that moment, except he deferred you. Well, that sends a signal to the FAA because the FAA assumes that the doctor did the correct thing. And now you're deferred to the FAA, and now you're looking at a minimum 3 to 5 month wait. And then there's an AME in the middle. He's kind of a professional AME, but he's not a high volume exam guy. Well, that's the guy you want. How do you find that guy? Well, that's very difficult to do. Now, that's kind of how we started our business, because we are that guy. We can be that guy, and we will do confidential consultations. So there's really no good reason to stop treatment for something, because chances are you'll be able to get your FAA medical. We might need to work with you and your doctor on what medications are being used, and to optimize both your health and your ability to fly. And then, in fairness, there are certain times when it is just not safe to fly, and that's okay. That's when it's time to get better. If you have a broken leg, you can't fly with a broken leg. You got to wait until your leg's better.
Yeah, that's a great point. Thanks. A question came in from one of the attendees. The individual is currently involved in a deferred medical due to FAA questions arising from frequent PVCs. He's been advised from AOPA that PVCs of and by themselves are not disqualifying. Could you please speak briefly on the topic of PVCs and the follow-up questions asked and tests required by the FAA?
So first, I will say I love the AOPA. I am, I forget what level member. I'm not at the highest level, because the highest level is like their full medical help, which I don't need. But I'm a big believer in AOPA. I do think they are a fantastic advocacy organization. Their medical help is very limited. They can read the relevant sections of the AME guide to you, but they do not have professional physicians on staff. They don't really have any professional aerospace medicine folks on staff. So PVCs that are 2 or more found on the ECG requires testing. Now, that testing is going to depend on what is subsequently found. So on a stress test, if the PVCs go away, with increased activity on the stress test, boom, that's all you need to show, and you're going to be able to get your medical at the exam, assuming your AME knows what they're doing. If they do not go away on the stress test, now you need to have a more complete cardiology evaluation plus minus an echocardiogram. If there's no structural deficits found and no heart disease found, boom, you're back to your AME can issue your certificate. If there's anything else questionable found, then it has to go to the FAA for a final disposition. So it's a little bit more involved than, PVCs alone are not disqualifying.
Great. Thank you very much. Next question. What are the common causes of pilot impairment and incapacitation? The questioner observed that one Australian study suggested that plurality of impairments were food poisoning and GI issues. How can medical predict this?
Yeah, so a medical can't predict things that are sudden like that. So your average sickness of something like that is going to be pretty short. So a lot of people kind of confuse food poisoning with a gastrointestinal infection. So in general, food poisoning is going to come on within 2 to 4 hours of eating a food, and it's going to come on fairly suddenly. So that's something that is almost impossible to predict. But, some of these are the pilot themselves has to do that self-assessment. If you're starting to feel queasy and feverish as you're walking to your plane, well, that's not a time to go flying. The FAA medical is not going to be able to predict that because that is not a medical condition that is known and can be risk stratified. And that's what they're trying to do. They're trying to take known medical conditions and risk stratify them. In that case of an acute, gastrointestinal issue, the FAA has no way to know that. The other thing is we're looking at if it were not the food poisoning and it was an actual gastrointestinal illness, that does typically kick in around the 12 to 24-hour mark. You're going to start feeling bad over a period of time, and it's going to start getting worse and worse and worse. So again, that's something that the pilot should be able to pick up on. And unless you're looking at 4 hours later, they're now doing an international flight. Okay, that's a long flight, so it may come on during flight. Again, not something they can risk stratify. So they can only risk stratify the known things. But what's interesting is this is like a study, I forget the name of it, but it was done on World War II bombers that came back. And they looked at the planes that came back and they said, okay, here are the areas most commonly shot up. Let's put armor on these areas because they're most commonly shot up. And it was somebody else that said, no, these are the airplanes that made it back. So those parts are okay to be shot. We need to armor up the parts that weren't hit because that's where the other planes are getting hit. So when you look at it from that perspective, with pretty good risk stratification through the FAA process, the most high risk stuff isn't making it to flying in the first place, or it's mitigated because they know they're doing it well, or they know they're forcing pilots to receive at least some level of treatment in order to get their medical. So you're eliminating a bunch of those potential risks already. So they're not even in the pool of potential risk because they've already been eliminated. So it skews the results to, of course, the most common thing is an acute issue that the FAA wouldn't see in advance anyway.
Excellent, thank you. Next question is, can you give an overview of the process of renewing a special issuance certificate for sleep apnea once it has lapsed for over 1 year?
Really, there's no difference than if you were just going back in for the renewal. So once you get the initial sleep apnea, that requires a minimum of 30 days treatment, assuming you're using a positive airway pressure device. At your annual one, you have to provide the whole year worth of compliance data from your machine. And then you have to have the certain percentages. I forget off the top of my head. I think it's 90% and 6-hour average, per night. And so you'll have to provide that. If you stopped flying and then you stopped using your CPAP and now you want to return, you're either going to have to provide that entire length of time, or if you stopped and you're going to start again, you need to show at least that 30 days again. But you'll need to explain that to the AME at the time. Hey, I stopped flying. That's why I wasn't, and I wasn't using my CPAP because of whatever, I was out of the country or something like that. You're going to have a decent explanation. But if you can show, hey, I'm back on my treatment, here's a minimum of 30 days, you should be able to get your medical with that.
Great. Thank you very much. And Keith, that's the end of the questions that came in through the portal.
Okay.
So I hope that all the PMOPA members found this to be as informative and valuable as I did. For additional information about aviation medical topics, Keith and his colleagues regularly post to their blog, and you can find that at wingmanmed.com/blog. That's wingmanmed.com/blog. Keith, thanks so much for your time and expertise. Greatly appreciate it, and hope to see you at a PMOPA event in your new PA-46 in the near future.
All right. Thanks a lot.
Thanks, everyone.